الأنبياء والمرسلين. The Vision 2030 for Saudi Arabia is to open the eye and to make it one of the wonders around the world. And upon that, the theme of this conference, as our chairman said, it's going to be the challenges in the management of rheumatological disease in general, and I'm going to focus on psoriatic arthritis in particular. So I'm going to go ahead over the case presentation, followed by the guidelines both for the EULAR as well as the GRABA and for any updates. Then the residual unmet needs, followed by the challenges in the management. And finally, I'm going to go over an update from both the ACR and the EULAR abstracts. So first of all, I would like to thank this case in the courtesy of Dr. Yusuf Narman, and I would like to thank him for sharing the management of this patient with me. This is a 56-year-old gentleman who was actually a pilot and who have been suffering from severe skin psoriasis over the past 30 years. It was so debilitating to the extent that he cannot perform his job very well. And at that time, we're talking about almost more than 30 years ago, he was managed with local treatment in addition to the oral DMARDs. Unfortunately, his skin did not improve, and at that time, he was started on in 1997 on an infliximab. He felt perfect. Wow, I have the wonder drug. And believe it or not, he was the first patient in Saudi Arabia to start infliximab infusion at that time. Then, within the second dose, he developed a severe allergic reaction in which he was managed. Despite that, they re-challenged him because it was the only medicine available at that time, and it was a good hope for him. And unfortunately, it didn't work out. Etanercept came on board, and it was started, and unfortunately, the patient did not get any benefit. Adalimumab, he did notice that his joint improved, but there was no effect on the skin. Ustekinumab was given for him for 1 year, and it worked in the beginning, but unfortunately, he developed secondary failure. All 17, both have been tried. They're available in the market. In the beginning, he felt, wow, I feel the best. I'm doing very good. Unfortunately, he developed secondary failure. Tofacitinib, JAK inhibitor, was introduced to him, giving a hope that it may help both the skin and the joint. And unfortunately, only the joint improved, but neither the skin. Unfortunately, because of the severity of his disease, he had to apply for early retirement, and he quit the job of his life that he likes. Risankizumab have been introduced, and in which he noticed that there was improvement in both the skin and the joint. And this is the picture for him before and after. And hopefully, let's cross our fingers that he's not going to get neither any secondary failure nor an allergic reaction. So when we talk about the prevalence of the domain in psoriatic arthritis, if you look at multiple studies, each one of them will give you different domains. But I like to look at one overall study or one overall real-world experience. I know better than the core Avesta registry, formerly called the Corona, in which it involved more than 19,000 study visits, almost 5,000 patients, and more than 600 rheumatologists. And you could see that both the skin as well as the joint, they are compatible to each other. Now let's look at the PSA recommendation. When I teach my resident and the fellow, I tell them there's the ACR, the EULAR, and the GRABA guideline. But the one that I really like, and I teach my trainee, is to look at the GRABA guideline. For one simple approach, it's a domain predominant. And it has been updated from 2015 up to date, and it's published. What's unique about the GRABA, different from the ACR, different from the EULAR, it's a domain predominant. And it leaves the decision to the treating physician, taking in consideration the comorbidities in addition to the associated conditions shown in orange, the far right side, and to individualize the treatment. Now, when you look, in each box, there are many options with no special order. It's up to you, the treating physician, and to put in consideration what the patient fits in order to decide. So let's go over some of these. Now, when we talk about the joint, we know that all the biological therapy, they were applicable and they were approachable to the standard of care, that is the adalimumab. With the exception of the guzilicumab and the risankizumab, in which both of them are comparable to the placebo. We don't have up to the standard of care yet. So where's the difference? Since all of them is almost similar within the joint, it's in the domain. And that's what you have to look for in the patients. So for instance, in axial disease, up to my knowledge and up to now, the maximized trial is the one and only study that showed that there is an efficacy within the axial PSA compared to the placebo. We know that there have been a study, which was a failure study, for the IL-12/23 inhibitor for ankylosing spondylitis. Based on that, the FDA did not approve any of the medication that contain or inhibit the IL-23 until there's a specific study in which the primary endpoint is the axial involvement. And if you would like to learn more about the maximized trial and the Cosentyx, please join me for today at 2 p.m. for the Satellite Symposium. Let's talk about the residual unmet need. We all know, despite all the medication that we have that have been introduced since '99 in Saudi Arabia and in the Arab world, there's still unmet need for the patient. As such a patient, they don't meet full remission. We know it's very difficult to be achieved. Even low disease activity, it's hard to achieve. But I would like to look at one point. Look at the references. The maximum reference over there for any study about the residual unmet need, it was published in 2019, which means, look at the timeline. That's the line when the IL-17 have been introduced, and it was still intravenous. We didn't use it much at that time. Then we went through the COVID pandemic. Actually, the IL-17 and the rest of the medication came widely to the world after the COVID pandemic. So right now, we have more than 10 biological therapy for psoriatic arthritis. So we need a new study depending on the new availability of the medication. The second unmet need, despite what we do for treatment, still the patient, they are complaining from pain, almost 90%. And that have been shown in the registry. We'll talk about it later on. Is it related for the disease or something else, or is it even fibromyalgia? The third unmet need, which we all see in the clinic, is the needle phobia, in which the patient, they preferred oral medication, and even more infrequent route of administration. But again, if you look for the frequency of the route of administration, it was at that time every 1 month, and there isn't yet every 2 to 3 months. So let's go over the first challenge. It's the personalization of choice of therapy in psoriatic arthritis patient, and what I call it as precision medicine. This is what we all do in the clinic. Whenever you have any patient in front of you, you will take into consideration the comorbidities, the associated condition, and the patient preference, and then what you actually have and the safety in your hospital. This table is to help you. It was published actually in 2020 based on the EULAR guidelines. Come on, it's 2 years ago, almost 3 years. We have more medicine since then. So let's update it, and actually there haven't been one. With the help of the medical team from AbbVie, as well as from Janssen and from Novartis, I created this table. Please feel free to take a screenshot from it. So the first challenge is to know. طبعاً الجهل عدو الإنسان, and we have to increase our knowledge in order to know how to help our medicine. And if you could see in the first 2 lines that the TNF inhibitor, in addition to the IL-17, they lie with the same lines that they treat all the domain and cover them. Of course, you could see with the exception of the etanercept for the associated condition. We talked already about the IL-23 and the IL-12/23 inhibitor, that there is no recommendation for the axial PSA. So I'm going to go over a case with you that I saw a couple of months ago. He was a 19-year-old boy. So he's not a boy, he's a man. But he came to the clinic with his mother because he developed a viral encephalitis just a couple of years ago that unfortunately left him a bit of mental retard. So in other words, he's almost like a pediatric patient. And we are all blessed, honestly, as an adult rheumatologist. We're not like our pediatric colleagues, in which they have to deal with the patient and the parents. So this is one of the challenges in such a patient, that you have to deal with the parents as well. So his story was the following. He was having a joint, he was having skin, as well as axial disease. And he was on TNF inhibitor, but it wasn't doing a great job. but that was as good as it gets. That was what we had at that time. So when the IL-17 were available in the market, it was rechanged. And he said that his skin totally improved, and he felt very good with regard to the joint. On follow-up visit to his rheumatologist, they noticed that he was having enthesitis of the Achilles tendon, and it was ultrasound confirmed. And they decided to change it to the IL-12 and 23 inhibitor. So his mom, she came to me for the consultation, tell me, what should I do? He's having a severe back pain, an MRI, and it was confirmed that he's having the sacroiliitis, which is active. So let's apply this, and she was requesting to go back on the Cosentyx. Let's apply this patient to the table. So this patient, his domain are the following. And with regard to the IL-12 and the 23, there's no recommendation, and as we said, it was a failure study with regards to the axial PSA. When we talk about the precision medicine, this is a not new concept. This concept has been going on over the past couple of years. And whenever I go to the American College of Rheumatology, I know the Japanese people, they have a special interest in that. And they have been doing multiple flow cytometry tests. And I presented this in all my lectures within the update in the ACR. Now this year, they upgraded their study. In addition to the flow cytometry, looking at the T helper cell 1 as well as 70, they actually divide them into two groups. The standard of care in addition to the precision and medicine. Is it a surprise that the patient with the precision medicine, based on the flow cytometry, they did better with regard to the ACR improvement? Perhaps not in the skin, but yes, indeed, in the ACR improvement. The problem of this, it was randomized. The two arms were not equal, and it was a small study. That's why keep your eyes open for the next EULAR, for the optimized trial, in which patients with PSA have been randomized with flow cytometry to receive either treatment, the TNF inhibitor as well as IL-17, and perhaps more cytokines and more treatment option. This go with the concept of precision medicine, predictors of response. This is we have been going on and searching over the past 10 years. Why? In order to prevent the restarting of medicine, the recycling of medicine in the patient, and perhaps they will get morbidities from it. The second challenge is the management of the associated comorbidities or conditions. Now, we know from previous cohorts, such as the CATCH, that PSA patients with comorbidity, they have a worse outcome. What does that mean? They do not respond to medication beautifully as we intended. And the GRABA, as well as the EULAR, have been recommended to treat the comorbidities and refer the patient to the proper specialty accordingly. Now, this table, it presents the comorbidities that the GRABA and the EULAR, they requested to look for, specifically heart disease, liver disease, and no wonder, depression and central desensitization syndrome. So let's go over a couple of examples. Now, remember, this table is opinion-based. It's not based on systematic literature review. The first table of the GRABA, it was based on the systematic literature review, but this is not. It was opinion-based, and I know that a couple of you may have a problem with it and may disagree. So let's go over a couple of examples. For instance, they state here that the DMARD in the form of the methotrexate as well as leflunomide is contraindicated and to be avoided in patients with fatty liver. We do have a couple of us fatty liver patients in which they were started on such a treatment, and with the follow-up with the hepatologist and doing the proper screening and the follow-up, they're in a great condition. Number two, we know that the TNF inhibitor, they're associated with high signals of TB, and we're taking the precaution of that. Studies have not been shown that the IL-17, the IL-12, 23, or the IL-23 are associated with increased risk of TB. You know something? We're in an endemic country. We still take precaution, and they did label it based on the Saudi FDA approval that take the precaution for the TB. The TNF inhibitor have been stated to be avoided in patients with CHF as well as with demyelinating syndrome. And finally, there's the JAK inhibitor, the era of the treatment. in which because of increase, there's a perhaps increase of the risk of the DVT-PE. Based on the USA, it have to be given after the TNF inhibitor inadequate response, but in the UE, after the conventional DMARD, inadequate response, putting in consideration the risk factors. Number 3, treatment sequences and combination. Do we know what's the best sequence to start in such a patient? Unfortunately, no. We go based on the trials that we know, based on that you have to start TNF inhibitor first and then the treatment. It's not evidence-based. It's not systematic literature review-based. It's based on the randomized trial, and because we know how to deal with TNF inhibitors because they have been in the market almost for 15 years. So what about the combination? Actually, the combination of the biological therapy, it's not a new concept. For those who have been in the 90s, late 90s, early 2000, they know it's not a new concept. It has been tried in the past with etanercept anakinra in addition to the TNF inhibitor and abatacept. And there was increase in the risk of infection with no much improvement, about the double, 3 to 6% increase in risk of infection. You will say in your mind, well, 6% is not a lot if the patient was getting better. But given the fact the patient did not get better, they consider it as no, and nobody talked about it. Over the past couple of years, people have been digging their toes. They have been sneaking in and looking into that. And you know what? Our colleagues from dermatology as well as GI, they have been doing a better job than us, because they have a very devastating patient who have severe IBD with a SPA involvement, axial or joint. They used combination therapy in the form of the guselkumab and the golimumab in the Vega trial that have been presented in the ECHO meeting last year and the year before. And you could see the results. The combination therapy did better. What about the side effect? That's what I care. The side effects of infection, actually, it wasn't that much higher. So this is something to look into. Now, in Spain, they have been doing a small studies last year and this year. They have been looking at the combination therapy. Remember, the targeted treatment, the more specific, we hope the less likely that the patient will have side effects. So those IBD with SPA patients, severe cases, and the number of the cases, they were actually a bit higher than the authors. And they used multiple regimens, IL-17, IL-23, IL-17, IL-12-23, and IL-17 in addition, or TNF inhibitor and the targeted synthetic DMARD. Third of the patient improved, third of the patient actually minimum, and actually third did not get worse as well. The side effect, only 2 patients, in which one of them, they have severe chest infection and the other one is bacteremia. There's an ongoing trials, and you could look at it in clinicaltrial.gov. It's called the Affinity for the combination of golimumab and guselkumab in patients with PSA. The fourth challenge, pain in PSA. Is it fibromyalgia or enthesitis? Please, do not over-diagnose your PSA patient with fibromyalgia unless you examine the enthesial point. I have been talking to many MSK radiologists around the world, people from the SAS, people from the EULAR and the GRABA. I tell them, listen, I'm not talking about the large enthesitis, the Achilles tendonitis, the plantar fasciitis, which is easily to be diagnosed. I'm talking about the small body enthesitis that even if you went to the best MSK radiologist, he will tell you it's hard to be diagnosed. I cannot detect it by an ultrasound or even an MRI. So keep it in your mind. Because enthesitis, it's the phase before the joint involvement. And we all have in our practice, many patients have been misdiagnosed with fibromyalgia, and then they turn to have a severe PSA. So what I teach my fellow always, well, if you have an enthesitis, this means that your response will be less. And please look for the enthesial point as well as the fibromyalgia point. And keep it as a high index of suspicion. Challenge number 5, can we stop medication? I will just share with you one of my patients. Actually, she came for a second opinion, a young lady who had been on DMARD, did not improve, switched for TNF inhibitor, improved, stop. Went to another TNF inhibitor, adalimumab first, then etanercept, improved after 1 year, stop. It failed. Right now she's on Cimzia. And she came to me and she told me, Doctora, what should I do? I remembered immediately that PSA patient, the recommendation have been stated, if you stop them, there's 50 to 100% flare up. So per the GRABA guidelines, you have to be very careful when you taper such medication, and it's a patient-physician shared decision. I'm just going to go over updates quickly from the ACR and the ULR. I'm not going to go into detail, just the thing, practice changing. You know something? Across the world, even in the UK, there's still a delay in the diagnosis of PSA. There's underuse of the DMARD. And what not better than telling our colleagues from different specialty use a screening method in which one of them is the pest. They will tell us, well, we're a busy clinic. I say, it's fine. If you have one patient with high risk to develop PSA, it's going to be your obese patient. Choose from all the 20 in your clinic, just the obese, and screen them for pest. We always have been looking if there's any way for a patient with severe PSA that we could prevent PSO, that we could prevent PSA, and we couldn't. But actually, please pay attention. There's an oncoming trial called the PAMPA trial in the next ULR, in which patients with severe PSO have been giving TNF inhibitors or biologic, and they got better. What about cycling versus switching? Which one is better? There wasn't much difference between either. But when you look at the retention rate for different mechanism of action, it did better. And the IL-23 was not better than the IL-17. Because of our patient do have many comorbidities and cardiovascular risk factors, so you wonder, what about if I did, like for an example, if my patient has severe PSA, they will have cardiovascular disease. In Toronto, Canada, they applied the cardiovascular risk estimate, including all the PSA domain, and actually it did not make any difference. So the take home, do a cardiovascular assessment on your regular basis, like what you exactly do in internal medicine. Nothing is specific, and your patient will be fine. Now, the last thing is with regard to the risankizumab. The risankizumab, actually, there have been post-hoc analysis with regard MTX inhibitor, is it better versus not? If they were in methotrexate, long-standing disease, and the subgroup analysis didn't show any different, so it could be a monotherapy, early versus late disease. And I would like to ask you to join us on Friday for the satellite symposium, and it's going to be a unique one, because they're going to be one of my colleagues that I'm proud to present with from dermatology from King Saud University, and we will have a shared physician decision. So let's go back to our patient. What happened to him? Unfortunately, he started to have renal impairment, and actually he was diagnosed by nephrology to have IgA nephropathy, and unfortunately he ended up in dialysis. Myself and the nephrologist, by systematic literature review, actually, the multiple biological treatment have been associated with many morbidities, in which one of them is renal failure that is severe to end up in dialysis. And I'm proud to say that we had a meeting yesterday in the SSR committee, and we are conducting a study for patients who receive multiple biological failure to look at their outcome for the morbidities in particular. So in summary, PSA management, it has to be per recommendation, and the best is domain approach, whether it was the GRABA or the ULR or the ACR. Consider, please, the related condition as well as more comorbidities, and be aware, the best treatment, be aware of the evidence, be aware of the specific involvement and the specific domain, because as you all know, that the IL-17 and the TNF inhibitor, they lie in line with the same table. Please avoid overtreatment in our patient in order to prevent morbidities. Thank you so much for your attention.